things that you can see. And then what are the meatuses? The space in between the concha, okay? So today we're going to talk about lobes, lobules, segments. So just keeping all of the nomenclature straight is going to be probably the most difficult thing, because even today is all anatomy. And then tomorrow we'll start to get into like the respiratory physiology. And it's not that difficult. And there's some stuff on the slides today that I'm not going, I want you to know about. But that's it. I'm not going to test you on it. Because when you start to really get into the lung segments, it's insane. The nomenclature's insane. And really what that comes down to is surgical anatomy and even radiographic anatomy. Because you can remove certain segments of lungs in a flush pneumonectomy. But for our purposes, we just need to know more gross anatomy. Okay? Anyway, so we'll start with the trachea. And we'll work our way down through the bronchial tree. And we'll talk about the lungs and the lung perfusion itself, all right? So, air passageway, right? What do we talk about? What's the only complete ring of cartilage on our trachea? Huh? The cricoid, right? The cricoid. What do the rest of them look like? They look like C's, right? And in the back, the posterior, there's a groove, right? A soft groove where that C opens. And what sits in that groove? The esophagus. That's right. Okay? And the tracheal rings, they give it structure so that it doesn't collapse with inhalation, otherwise it really would, right? So looking at this, we have the back of the tracheal ring. This is the trachealis muscle, and yeah, the anterior portion of the esophagus sort of sits in that groove. So the tracheal cartilage really does, in certain respects, give some protection and structure to the esophagus itself as well, okay? Layers of the tracheal histology is not that exciting. The biggest thing to remember is that, like, we saw that delineation of where we started to have that ciliated epithelium, right? When we get to the real respiratory zone, or really the air movement, so we want to have that cilia to do what, essentially? To just move stuff out, right? Catch any, particulate matter that's in the air that we inhale, and to help bring that mucus, so expectorate it if we need to get rid of that stuff, right? Okay. And really, what is the trachea as part of? Which zones? Does anybody remember the two zones we talked about? There's the conducting zone and the respiratory zone, right? And what is the trachea? It's an airway passage, right? It's just like the esophagus. Is the esophagus a part of the digestive system? Yes. Does any digestion happen in the esophagus? No. It's a tube. And the esophagus really is a tube. Now, it does have that ciliated epithelium to help protect downrange structures, but it really doesn't have any functional capacity as far as gas exchange, right? Okay? And that is good. That nomenclature finally makes sense a little bit. When we get to the respiratory zone at the respiratory bronchioles, that's when we have true respiration, exchange of gases, okay? And so another picture, just so you see, again, here's our only real true ring, goes all the way around, the rest of them are just C's, right? And as we move down farther and farther into the smaller and smaller airway passages, those rings are going to give way to plates of cartilage, just little pieces rather than true rings around, right? And then as we move even deeper into the smaller and smaller area passages like the bronchioles and beyond, we're going to trade that cartilage for smooth muscle, right? So it'll make sense as we get down a little bit. But trachea is pretty simple, right? It's the tube where the air goes down. And what is the end of the trachea called? The carina, that's right. The point where it bifurcates into the main stem bronchi, right? And these, you're going to have two nomenclatures, of course. We're going to go for bronchi, main, primary, secondary, tertiary. But clinically, you're going to almost always refer to them by main, segmental, and so on and so forth. So that'll make sense. So in this one, this is really the more clinical nomenclature versus the more anatomical nomenclature is the primary bronchus. Okay, if that makes sense. But seeing here, right main stem, shorter, more vertical, and wider. Why would that be important clinically? Go ahead.
When you intubate someone, you might right main stem.
That is correct. That is one of the reasons, right? That is one very important reason. When you do intubate somebody, endotracheal intubation, if you go too far, if you push the tube in too far, it has a tendency to ride into the left or to the right, the right lung. And so if you have the tube, you're only ventilating one lung, You had to back it out a little bit back into the kind of where it belongs, right? So that's why you listen to lung sounds after you intubate somebody, to make sure that you have breath sounds on both sides, okay? What's another clinical reason? Anybody have kids or anything like that? Yeah, they swallow stuff or they inhale stuff, they put a penny down there, something happens, they choke, a little peanut, they breathe in. Which way is it going to have a tendency to go? It's going to have a tendency to go towards the right because the right is shorter and more vertical, so stuff just sort of tumbles into there. So if you have a child and they have some sort of airway obstruction or something like that, a lot of times it's going to be on the right. And if you look at this picture, don't be deceived, because this is the right side over here. But this is the main stem bronchus, right? Not that whole piece, right? Not all of this, right? Just the piece I broke off, right? Because it looks like if you're looking at this, well, that's a lot longer than the left side, but that's the main stem bronchus. So that's just that little short portion is the main stem on the right side. And so stuff just has a tendency to make its way into there, right? Like ET tubes, like inhaled substances, so on and so forth, okay? And then histology is very similar. We've got ciliate epithelium, just like in the tracheonasal cavity, again, for the exact same reason. Right? It's going to create mucus, or the mucus goblet cells are going to create mucus. The cilia are going to help beat it towards the exterior so that anything that is particulate matter that doesn't belong in the lungs, that's going to obstruct actual respiration, is going to be sent out and not in, all right, in general, okay? And as we're moving down, so we're at the trachea, then we have the main stem. Now we're getting into smaller airway passages. If you look at this, like I said, this is the real anatomical term, whereas this is typically our clinical term, how we would usually discuss it. All right? So main, lobar, and segmental as we're going down. And they're named for what they do. Main bronchi supply the lungs as a whole unit. Lobar bronchi supply lobes. And segmental bronchi supply segments, and that'll make sense in a minute. But, so what are the numbers here? Each one has a main stem. Which one has, well, it's already on there, right? 3 to 2. We have 3 lobes of the right lung, 2 lobes of the left lung. And I know we haven't talked about the lung lobes yet. It's coming up. Just stick with me. All right. And then segments. Segments are where we're going to kind of break off a little bit. I'm not going to ask you guys to name segments. All right, because if you've looked at these slides, the nomenclature for them is very odd, all right, and there's no reason to memorize all those things. That's where it really gets in. The segments are really where it gets into structural, like surgical and radiographic anatomy. Because if you have a segmental bronchi where you have damaged lung tissue, you can take out a specific segment, and in that, and then the rest of it, the rest of the parenchyma that works, you can leave in. So that's where it really becomes important to know exactly what portion or exactly what terminal bronchi, or tertiary bronchi is feeding a section that doesn't work anymore. Do you take that out? Clinically, for us, not so important. Like when we look, honestly, if you look at X-rays, you look at CT scans, you see consolidations. You're going to talk about lobes, left upper lobe, left lower lobe, so on and so forth. Get down any further than that, then we're moving past primary care really into pulmonology. Does that make sense to everybody? Okay. So, and again, we'll get smaller and smaller and smaller. All right. So, right side over here, we have 3 low. Left side over here, see this main stem bronchi, very short. Okay. As we move down, the bronchial tree, lobar, terminal, respiratory. What does respiratory start? The respiratory zone. Exactly, the respiratory zone. All right. Alveolar ducts, sacs, and alveoli finally. We're gonna break these down individually into the structural segments and the functional segments. And I found some corrections that needed to be made in these slides, so I made them. So just stick with me. All right. But look at this. Right? That's how crazy it could get, but if you see this, this is technically our right main stem, and just to continue to highlight that. This technically is called an intermediate bronchus, but you can see why stuff would just sort of naturally make its way into that pathway. This is why I'm not going to ask you about individual lung segments, okay? Because one, it's not always one for one the way these are named or what the anatomy looks like given patient to patient. Obviously, there's a fairly significant amount of variation in these pathways, especially the really small ones. And as I said, teaching primary care, future primary care providers is not that important. So the point is, for you, don't spend time memorizing all of the words on this picture. Does that make sense to everybody? All right? I want you to know lung segments, and we're going to talk about lung segments and what that means, but I don't need you to know each one of them. Okay? Globally, what is a lung segment? Good enough. Fair? Okay. So as we go down this, as I already said, as we're in the trachea, in the larger airways, we have the rings, right? The C-shaped rings. We'll just call them rings colloquially, right? As they move down into smaller and smaller and smaller airways, the rings just become little pieces. They call them plates of cartilage, right? They don't even go all the way around or even partially all the way around. And then as we get even smaller, that cartilage, that supporting tissue, is replaced by smooth muscle, right? When we get to the really, really microscopic anatomy, right? And then you get down in the bronchiole, it's all smooth muscle, okay? Terminal bronchiole, so named because they are the end of the conducting zone, right? So what is happening from the mouth, the oral pharynx, to the terminal bronchioles? Airway conduction, movement of air, that's it, right? No air, no respiration, okay? And you get to these cells, the club cells, they produce a little bit of surfactant. And before we get there, does anybody know what surfactant is? Yes? Sorry, go ahead, percent. You, Matt, what's up?
I was answering the question.
Yeah, what's up? What'd you say?
So it's called lung lube.
I mean, okay, sort of. Sort of, but it has a much more significant function than just lubrication.
Prevents that
It keeps a low surface tension in the alveoli, right? If you have a high surface tension, you have these things when the alveoli collapse, or when we exhale, the alveoli would collapse, and the high surface tension would keep the membrane of the alveoli together, and it would take a high pressure to pop them back open, right? So the surfactant keeps a low surface tension so that we're allowed, so that that thing stays open, right? Right? Where a lung lube, probably a better term for that when you're treating your former medics is our pleural fluid, right? Our pleural fluid is literal lung lube that moves between the visceral and parietal pleura, and also helps a high surface tension so that the visceral surface, the lung surface, keeps in contact with the parietal surface, which is the inside of the thorax, and keeps the lung inflated so that when you exhale, it doesn't shrink, you don't have any kind of pneumothorax or anything like that. And this will all make more sense in a minute. Good job, you guys. All right. So, terminal bronchioles stop to about right here. All right, and we're going to start talk to you guys about some of these terminology off this slide right here, off this picture, because it is a very good picture and it gives a lot of information. So, terminal bronchiole, this branch of the terminal bronchiole down to the alveolar sacs here, the individual alveoli, it's called a lobule. Now, don't have to write all this down. We're going to go over it again when we get to it in the lung segments. I just want to show you this stuff now, okay? So if you're thinking none of this is it's in the slides, just give me a second. So that's called the lobule. A lobule is really a structural unit, okay? And why would it be a structural versus a functional unit? Just that portion. Yeah.
Because your functional unit is going to be the respiratory bronchiole.
That's correct. So basically, the reason why it's still called a structural unit is because it does contain a portion of terminal bronchiole. And what is a terminal bronchiole? A conducting passageway, not a respiratory passageway, okay? When we get down into, now you see this little dotted line right here, this guy, this is called an sinus, right? That contains the respiratory bronchiole and then the alveolar sacs and the individual alveoli. That is the functional unit, okay? You remember me talking about parenchyma versus stromal tissue? Similar to that, stromal tissue is what? Structural, supportive, whereas the parenchyma is the functional tissue of the actual organ, right? So the nephron in the kidney that we've already learned about is the parenchyma, the functional tissue, versus the stromal tissue, which just supports and gives structure to the kidney itself, all right? Now, looking over here, this is our terminal bronchiole cutting off like right there. So each terminal bronchiole will give rise to multiple respiratory bronchioles, okay? And if you notice, what starts to pop off in the respiratory bronchioles? Alveoli, right? Alveoli start to pop off in the respiratory bronchioles. And why is that important? Because that's the respiratory portion, okay? I know I'm sort of beating a dead horse, but does this make sense to everybody? All right? And then you get down farther and farther. From the respiratory bronchioles, you'll have alveolar ducts, which is like the stem of the bunch of grapes. Then you have the alveolar sacs, which to me looks like a bunch of grapes. And then the alveoli are the grapes. Okay? So you have an alveolar duct supplies a bunch of alveoli. Alveolar sacs are all the alveoli that are connected to that same stem, and then the individual grapes are the alveoli themselves. That's a pretty easy representation. We're going to go down that whole pathway, but just I wanted to show you because I think it's a really good picture. Does that make sense to everybody? Yeah? Okay. Okay, just a quick bit about innervation. So sympathetic stimulation, right? Autonomic nervous system, that's what the ANS stands for, sympathetic stimulation. What do we need to do to get away from the tiger? Breathe, right? Breathe. And breathing more specifically to get oxygen to our big leg muscles that are helping us run away from the tiger, right? So that's what it does. It opens the airway, bronchodilation, okay, to help facilitate air movement into the lungs and then into the tissues so we can get away from the tiger, all right? Parasympathetic, we've just eaten the tiger, now we just need to lay down and digest and enjoy the tiger, right? So we don't need all of that lung tissue. So bronchoconstriction, more secretions, right? Okay, acetylcholine. Does that make sense to everybody? Simply, that's as simple as it needs to be for right now. But cholinergic receptors. Have you guys talked about the difference between cholinergic and anticholinergic? So cholinergic is wet, anticholinergic is dry, right? Any of you who maybe have elder relatives who have COPD, a chronic obstructive pulmonary disease, or if you've heard about, if you've had, experience in chem bio, so like the anticholinergics help dry you out, right? So we give a medicine for somebody who has chronic secretions, chronic oversecretions in their lungs for COPD, and anticholinergic called ipratropium to help dry out their lung tissue so that they can breathe better, modulate these secretions. So anyway, that's why some of these medicines start to work, okay? Because they counter effect that overproduction of those secretions. Any questions about the bronchial tree thus far? You guys okay? All right. So let's talk about the lungs. Two of them, usually. Okay. Separated by the mediastinum. What's the mediastinum? It's the middle, right? We have a complete mediastinum. Humans have a complete mediastinum, meaning that we have essentially two separate air chambers, okay? If you lose one lung, you will maintain the other lung, all right? If other animals that you may work with in your training have an incomplete mediastinum, meaning that if you open the chest on one side, you have to breathe for them because they will lose both lungs. They don't have a fully integral mediastinum. Air can go across. Not so with humans, fortunately, okay? What makes the mediastinum is all of the stuff in the middle, okay? And some connective tissue, of course. Helps separate the two in distinct lung chambers, if you will, okay? Looking at that. Posterior mediastinum, anterior mediastinum, so all of this. So if you were to puncture cavity, some kind of penetrating wound into right chest, your left chest will maintain, assuming that it didn't go all the way across the mediastinum. And that is important to you clinically, because then you could just sort of focus on that one bad lung, okay? So I mentioned this already. We've already talked about what is a parietal surface, what is a visceral surface, right? So what is a visceral surface, just in general? A covering of the organ itself, right? What is a parietal surface? Covering of the exterior, the cavity covering. And we have pleural membranes on both of those, on the interior of the chest wall and on the exterior of the lung. In the middle there, we have a pleural space. And what is in that space? Lung lube, pleural fluid, right? Pleural fluid. And that really is what that is. That maintains a high surface tension to keep that lung tissue in contact with the inside of the chest wall so that you don't have collapse of the lung tissue, so that it stays open. Because how does the lung move? What moves it? What opens the chest cavity? Diaphragm, moving down, expanding your lungs, lowering the pressure, air flows in, right? When you exhale, your lung doesn't like a balloon, it just gets smaller within the cavity, but it adheres to the wall to maintain integrity so that you can take that next breath, right? Otherwise, you'd have to have positive pressure to open that lung tissue, right? Okay? And so if you see this, I don't know if we ever discussed this term, but what is a reflection in anatomy and physiology? Anybody know? It's basically a fold on itself, right? And that's exactly what happens. So the pleura reflects back onto itself. And that reflection is what creates that pleural space. And so the serous fluid in the serous production of the fluid in between that reflection, in that space, is where pleural fluid lies, okay? Not a whole great deal of fluid, because you just need enough to keep it moist so that you can move the lung, because the lung does move, of course. What happens if you have too much pleural fluid? Then you have to drain it, right? It can cause obstruction of the ability of the lung to expand, okay? And so this is a good way to think about it. I like this analogy, Anybody who's worked with microscope slides before, you have the cover slip, right? That goes on top, gives you a little bit of fluid, and that holds it on there. But it can still move around, right? But it holds it on there well. So the adhesion keeps it together. So the surface tension keeps it together. So we don't have any surfactant in that pleural fluid. And why? Because we want surface tension. We want that adhesion, right? If we had surfactant in there, we would lose it, okay? Does that make sense, everybody? All right. And this is just a picture. Now, this cavity space is only created because there is a camera in there. All right? In normal anatomy, those two surfaces would be adherent. All right? Meaning they would move back and forth. Those are pathological adhesions. And actually, not always pathological, but look at that lung tissue. What does it look like? But I'll tell you, they can do something like this, called a pleurodesis, if you have somebody who has a chronic pneumothorax, and they can actually abrade the upper portion of the lungs to create an adhesion like that so the person's lung doesn't keep collapsing. So they can actually do a procedure that does that on purpose. That is not that. That is not supposed to be there. But you understand why that's bad, though? Because imagine that trying to expand and contract your lungs, right? What does that create? Essentially, the sticking point, a friction point, right? So are you going to get full expansion of the lungs? Not necessarily, okay? And even a tiny little bit of limited expansion like that can lead to atelectasis, which is collapse of the alveoli in that spot, and that can create an area for potential infection, so on and so forth, right? So it's just not supposed to be there. And again, just to illustrate a point, but does that make sense? Yeah? Okay. And then if you get air or fluid in the cavity, because this represents a pneumothorax. What does pneumo mean? Air, right? Air in the pleural cavity is not supposed to be there. You can also get a hemothorax or a chylothorax. You can get all kinds of different thoraces. Anything that's moving the lung cavity, the lung space. And what is really, whether it's air, whether it's fluid, what's happening? Or what's not happening? Full expansion of that lung, right? And again, the lung, as it ceases to expand fully, it'll collapse on itself, it'll create atelectasis and get smaller and smaller. What this picture represents is a tension pneumothorax. And what the tension represents is the actual, you'll see tracheal deviation, it's starting to impede on the heart and on the other lung, right? If you wait for tracheal deviation, you have waited too long, okay? So, but does that make sense? Every time this person breathes in, air expands into that cavity because of the injury to the lung, and it just gets worse and worse and worse and worse. And what do you gotta do? You all know. Yeah. Let it out. How long is that gonna last? Not very long. Okay. So, it's not definitive by any means. Anybody ever seen that stupid Marky Mark movie? Three Kings, right? Yeah, where they put a little three-way stopcock and like he's just walking around and like, yeah, that does not work. All right. All right, lung anatomy. Any questions so far? No? If you've never seen Three Kings, skip it.
Ice Cube, man.
I mean, yeah, you're right. All right, so I'll tell you this again. This is really anatomical terminology. Most of the time, when you get radiographs, CT scans, when you listen clinically with the stethoscope, auscultate your lungs, you're going to talk about upper, lower, middle lobe, not necessarily superior, inferior. Same, but I mean, hopefully you can extrapolate the difference between superior and upper by this point, and if not, I'll help you out. So, 3 lobes, okay? 3 lobes being what? That's why we have 3 lobar bronchi, right? We have 3 on the right side, 2 on the left side, okay? Segments equal 10 on both, but again, we just need to know about the lung segments. We don't necessarily have to know each individual segment. That's why I don't even put it on here. A couple of highlights here we're going to talk about is on the left side, the lingula. What does lingula sound like to you? Tongue, right? It's just like this little piece of, this little flap here on the left lung. And then here we have our middle lobe of our right lung, which you'll learn best appreciated on a lateral chest x-ray. You see the consolidation best on the lateral chest x-ray, just based on the anatomy where it actually physically is. So if somebody has consolidation stuff in their lung, in that right middle lobe, that's the best view and you can see it. That's why you always like to get PA, posterior, anterior, and lateral chest x-ray, so you can see all of the stuff, right? So you can hear your lungs in the upper lobes, you can hear them above your clavicles, right? These are the upper fields, all the way down to the lower fields, okay? The right lung is a little bit shorter, wide. The liver, okay? The left lung has a little notch in it, why? Heart, right? Okay. Called the cardiac notch. The lingula kind of sits here. What is it? Switch. The lingula kind of sits here, like sort of at the inferior surface of the heart. Right? This little guy right here, little piece right there. Okay. And we're going to discuss the fissures here in just a second. Surfaces. Remember, I don't know if you might remember. I hope you do. But we talked about hard surfaces. These ones are pretty easy. Right? The costal surface. What's that? The surface that's on the ribs. The mediastinal surface is the middle, like where the hilum is, and the diaphragmatic surface is the bottom, right? You can envision that in your head. That's pretty easy to see where the stuff is. We're going to show you what the hilum is, but the hilus, so I can highlight the word for you. That's basically where all of the great vessels, the bronchi, where everything sort of penetrates into the lungs itself. I'll show you a picture of that here in just a minute. We just have an oblique fissure, right? So what's oblique mean? It's sort of a slashing diagonal fissure in our upper and lower lobes for the left lung. In the right lung, we have a horizontal fissure at the top and then an oblique fissure kind of going towards across the bottom, all right? The oblique fissure, let me show you this. The oblique fissure is here. It generally mostly separates the right or the middle and the inferior, but a tiny little piece of the upper and lower lobes. The major separation between the upper lobe and the middle lobe is this horizontal fissure. Okay? Does that make sense? The horizontal fissure doesn't necessarily go all the way across. There's still a piece of the upper lobe and the lower lobe that connect on the right side, and that is technically separated by that oblique fissure. Okay? Does that make sense? Yeah. Okay. And then if you look, so this, we have the costal surface, right? And then the diaphragmatic surface is the bottom. You can see it sort of groove where it reaches over, lays over across the diaphragm. This being the mediastinal surface. And this, where everything enters, is the hilum. Okay? That's where all the stuff comes in. The great vessels and the bronchial tree. Okay? And lymph nodes and stuff like that too, or lymph vessels, excuse me. Okay. Everybody with me? Okay. Segments. I got some changes on these slides. I want you to just pay attention. All right, for right now, I'll send out, when I comb through them and I find something that's inaccurate, I need to make sure I highlight it for you until I get it read to you. So I'm doing that. This says on your slide, I believe, A branch from a terminal bronchiole. It's not exactly entirely accurate. It contains multiple terminal bronchioles in a segment. Okay. The number is irrelevant, but it's about 3 or 4. And it's a structural unit, right? These segments are structural units. We already discussed why. And in case anybody forgot, the reason why is because they contain a portion of terminal bronchiole. So technically, it's not entirely a functional unit because that terminal bronchiole doesn't have a respiratory function. Is that clear to everybody? All right. So, segments go into lobules. Technically, they're called secondary lobules. Don't worry about that. It's not even a big deal. This is one of the other reasons you guys don't have to know this slide. This is an information-only slide, okay? Because there's just, again, what this does boil down to is the surgical anatomy I was referring to earlier. If you have a segmental bronchiole that is feeding a segment of lung that is no longer functional, right, downrange, right, the respiratory bronchiole and below are not functioning anymore, for whatever reason, injury, illness, what have you, fibrosis, then you can do a partial pneumectomy. You can take out that piece. That is important for a cardiothoracic surgeon or an interventional radiologist. That is not necessarily important to y'all. That's why I don't want you to spend time memorizing this list. Okay, yes?
Is this relevant to like emergency med, or is it only?
Not really, no. Emergency medicine is gonna, and I'm sorry to cut you off, but emergency medicine is gonna focus on much grander scale, bigger picture. You know what I mean? Left upper, left lower, upper, middle, lower. That's pretty much as far as it's gonna go. You know what I mean? You gotta keep that person alive until they can get to somebody else, pretty much. Does that make sense? Yeah. Same thing with this slide. Because even this numerology here is not necessarily saying from person to person to person. So this is just, I want you to conceptualize what a lung segment is, but I don't want you to memorize this stuff, okay? Especially when you look at this, depending on the anatomy, you'll see somebody that say 1 + 2 or 1 and 2, 7 and 8. Some people have a 7 and an 8. Some people only have 1. Suffices to say it's not necessary to spend any time on this other than what I've just done. Is that okay with everybody? All right. Now what this represents is a lobule, okay? A structural unit. Why? Because this little guy right here, the terminal bronchiole, and again, to beat a dead horse, what is the terminal bronchiole? A tube, right? A conducting tube, a piece of PVC pipe. It doesn't do anything other than bring air from the beginning of it to the end of it, all right? You'll notice the term acinus, right? We will define that. This then begins to represent functional unit, all right? But the lobules, again, where do they end? Technically they end at the alveoli, but where does actual respiration begin? At the respiratory bronchioles. After we get out of that terminal bronchiole into the respiratory bronchioles, now we have gas exchange happening. Remember that picture? What starts to bud off of those respiratory bronchioles? Alveoli. If you see it on an anatomical picture, when you start to see alveoli, now we can be reasonably assured that that is when respiration starts, because that's what they do, right? Okay. So looking at this here, and I have a new slide that I'm going to send you all, just relax for a second. This right here, this level of the respiratory bronchiole, is when that begins the functional unit. And that whole thing under that line, can you see the line okay? That whole thing under that line represents a pulmonary acinus, which is the functional unit. Because everything under that line is functional, right? The respiratory bronchiole. Then you see the alveolar ducts, right? The stems of the grapes. The alveolar ducts right here, right? The alveolar duct. Then that big bunch of grapes, the whole big bunch of grape, is the alveolar sac. Because the alveolar sac, technically the definition is all of the alveoli supplied by an alveolar duct. So the stem into the bunch of grapes, and then the individual grapes are what? The alveoli. Does that hierarchy make sense to everybody? Yeah? Okay. So we go respiratory bronchioles, ducts, sacs, alveoli. Okay? This, another word for this, elastic connective tissue. Let me ask if anybody knows. I think it's on the slide. It is on the slide, but let me know if anybody saw it. What is it called, like a dividing line between functional areas? Does anybody know? Septa. A septum, like a nasal septum, the septa. So a septa tissue. So it's all irregularly shaped. It doesn't always look like that, but what separates the lobules are septate, right? Connective tissue. What is a connective tissue? Stromal tissue, supportive, right? Not functional. Okay? So again, I will send this slide out to you because I want you guys to have the right one, but a pulmonary acinus is a functional unit versus the lobule, which is a structural unit. Does everybody understand that? I want to make sure that you do. Okay. Okay? And this is really the reason why it's functional. Distal. Okay? Distal to the tube. Okay? The real part of the tissue, the parenchymal tissue that does the work of the organ itself. Okay? I just put this slide back on here because, again, I think it's a good slide and it does represent what the acinus is versus the lobule, right? And this guy right here, I love repetition if you haven't figured that out yet. But this guy right here is the reason why we have structural versus functional, okay? And I know it's really hard to see that, but that little thing I drew in the box is the terminal bronchiole, okay? I really want to ask one more time, does that make sense to everybody? Is that clear? Okay. All right. So again, an alveolar sac is not the same thing as the acinus, right, as we have established. The alveolar sac is the bunch of grapes, everything that's fed by an alveolar duct, okay? And what feeds the alveolar ducts? What is the next higher thing after alveolar duct? Number 4? respiratory bronchiole, exactly, respiratory bronchiole, into the alveolar duct, into the alveolar sacs, into the alveoli, okay? All right. Also, you don't have to know how many alveoli, we have a lot, okay? We have a lot of alveoli, as we should, right? But you don't have to know 300 million, but it is, it's an outpouch. So looking at this, alveolar duct, bunch of grapes, and individual grapes. Okay? Cells within the alveoli are important, of course, as it makes sense. Two different things, two different missions, if you will. Okay? Type 1, which would be the most important, alveolar cells, gas exchange. Okay? The vast majority of the alveoli are made of the type 1 alveolar cells because that's what they're doing. And the type 2 cells, septal cells, secrete stuff, secrete surfactant, right? Put the S's together if you can't remember. Okay, type 2 cells, septal cells, surfactant. What does a surfactant do? It helps with our surface tension, right? It helps keep the alveoli open so they don't collapse on themselves. Okay? And those come from some club cells and some type 2 cells. So multiple different cells in the lower lung tissue, the microscopic lung tissue, make surfactant because it's important. All right. We also have phagocytotic cells, macrophages, right? Stuff will make it past the mucus and cilia into the lung tissue. Anything that doesn't belong there, those things try to eat it up to make sure they're clear. They're the vacuums in the alveoli, okay? Kind of like the Kupffer cells in delivery. You guys remember those? Yep. Okay. And then the monocytes sort of are the ones that help give structure and elasticity based on what they produce. But type 1 cells, alveolar cells, gas exchange, type 2 surfactant, and then you have the macrophages, which are really the dust cells. And they, think that's a good way to think about it, like dust busters, right? You guys remember dust busters, the vacuum? Okay. This is a representation. It's not super important, but what I like about this picture right here is that it shows you this little bit right here. Fused basement membranes of the alveolar and capillary epithelium. What does that tell you? If you have fused basement membranes of the two adjacent epithelia. Huh? I'm hearing it. What is it? They're continuous. Very little interstitial space, right? Gas exchange through septal diffusion doesn't have a long way to go, right? You don't want a lot of interstitial space. You don't want a long passageway for the blood cells to have to pick up that oxygen and deliver their carbon dioxide, right? You want a really thin membrane to make that happen. So that's why I like this picture, because it sort of highlights that for you. Does that sort of make sense intuitively why that's important? Not to have that long distance to travel through the interstitium? Okay. Do you guys have anything after lunch? You do?
Yeah, professional development.
Okay. We're gonna be done pretty quick here, so do you guys wanna hang out, or do you guys wanna take your lunch, or you're gonna take a break real fast? Like, we're gonna be done real fast. Alright. If you have to get up and go to the bathroom, go right ahead. But, surfactant, right? It lowers the surface tension of alveolar fluid. I've already explained that physiologically, right? If your alveoli collapse, and then they had high surface tension, and the surfaces of the collapsed alveoli are very adherent to one another, what does that mean for them when it's time to reinflate them? Either you can't, or it takes a lot of pressure to pop them back open, right? All right, so that surfactant inside that those type 2 cells make in the alveoli help keep that surface tension low so that when they do collapse, they're able to open up much, much more easily, right? Okay, does that make sense to everybody? So surfactant gives us lower surface tension because that's what we need inside the alveoli. versus high surface tension that we need in the pleural cavity, between the visceral and the parietal pleura. Does that make sense? Yeah? We want that lung tissue stuck to the outside, or excuse me, the inside of the thorax. We don't want the alveoli stuck together. High surface tension, low surface tension, okay? And here's that. The other important reason for that comes into later when we talk about gas laws. If you have multiple different sizes of alveoli fed by the same alveolar duct, you can understand just the simple physics of, think of a balloon, two different sized balloons, right? If you have to fill them both up, it would take different pressures. One would fill up before, one would collapse potentially while the other one was trying to fill up, right? The surface tension that is created, or the lack of surface tension that's created by the surfactant, helps both balloons fill up equally at the same time without one collapsing, okay? That's what this represents, okay? If you have a small balloon, like a very low, those little stupid tiny balloons, it's really hard to blow those things up, right? If you have like a bigger balloon, it's easier to blow it up. If you're trying to blow them up at the same time, one's not gonna go. With the surfactant, essentially, in a very, very simplistic way of thinking about it, both balloons fill up equally at the same time, and they're able to not collapse on one another. Does that make sense? A little bit, we're gonna talk about physics of that a little bit more coming up. But just on the surface, it keeps both balloons open and able to be filled. Is that sufficient for right now, you guys? Yeah? Maybe? Again, I know, without the explanation. But I mean, think about it, even if what I just said doesn't make any intuitive sense, you can wipe that out of your memory banks. Does it make sense about why we need low surface tension inside the alveoli? Because we want them easy. Oh, we gotta open them up. Easy, right? Okay? So, we've discussed this. This is a preface slide to what's coming up. But again, how does CO2 and oxygen exchange happen? Simple diffusion. It is not an active process. It doesn't need to be an active process. And again, if you have a very small interstitial space, if at all, for that gas exchange to cross, it's a very efficient process, right? Very efficient process. Okay? And the number of alveoli reminds me a lot of the number of microvilli. It's not important. I'm circling that just to highlight the point, not to make you remember that. We have so many million alveoli because what do we need? We need a high amount of surface area for that gas exchange to feed all of this. You know what I mean? In that efficient way that it does. Breathe in, breathe out. Air's moving around. If we didn't have that many alveoli, what are you going to have? Less oxygen, hypoxia, low CO2, and so on. You see what I mean? Okay. So just like we have those microvilli to dramatically increase that tube so we can absorb all the nutrition, we have the same amount of surface area to absorb all that oxygen. Okay? And again, simple diffusion. There's less oxygen in the red cell than there is in the alveoli, so the oxygen goes in. There's more CO2 in the red cell than there is in the alveoli, so CO2 comes out. That is gas exchange. Okay? In a nutshell, of course, but that is gas exchange. Looking at this, right? So what is everything? The terminal bronchiole and below, lobule, the respiratory bronchiole and below, sinus. Right, there you guys got it. All right. And you see, as you can imagine, just like in the small intestine, again, it's a very good analogy in my opinion, like sort of analogous structures. Highly vascularized, right? Just like pulmonary vasculature, the alveoli. Dense capillary network. Why? To take advantage of all that surface area, right? Really to take advantage of all that surface area for gas exchange and to make gas exchange an efficient process. Okay? Thank you guys for sticking with me. We're like 2 slides away. Excuse me, because you already know this. Pulmonary arteries, what do they have inside them? What kind of blood? Deoxygenated blood. Yeah? Right? And then they go, the bronchial arteries, right? These supplying the actual lungs, right? branches off the aorta. So the pulmonary arteries bring blood to be oxygenized, the actual parenchyma of the lung itself, fed by the bronchial arteries that come off the aorta. So if you look here, the right bronchial artery and then the two left bronchial arteries come directly off the aorta. All right? And then, as with everything else, pulmonary veins bring that oxygen-rich blood back. Does that make sense? So we already know how oxygenated blood happens in the lung. Pulmonary arteries, pulmonary veins, the actual parenchyma, and there's bronchial veins too, don't worry about that. The actual parenchyma of the lung is supplied directly off the aorta. There? That's it. Any questions from today? Yes, sir.
What was that tongue-like structure?
Lingula.
It was on a few different slides. What's the function?
It's just a piece of the lung, it's a piece of the left lung. It's not a true lobe, it's just a piece of the left lung. It's distinct a little bit enough to have its own name. So it's part of the functional lung tissue, part of the functional lobes, but it's not its own thing, it's not like a separate lobe like the right middle lobe is. Yeah. Yes?
The bronchial arteries are analogous to coronary arteries, correct?
Yes.
Is there a point in inspiration or expiration similar to the cardiac cycle where blood moves into those and actually feeds?
No, because they're not being filled at the cusp like that. So when the blood flows down from the aortic arch, it fills them up. They're on the descending aorta themselves, so they're being filled. Yeah. Anybody else? Somebody else, I thought? No? All right, you guys, thank you very much. I'll see you tomorrow.